All right, everyone, welcome back. Today, we're diving into the world of gastrointestinal health. We'll cover the essentials of the GI exam and then explore abdominal organs and their functions. Then we'll tackle GERD and we'll talk about peptic ulcer disease as well. We're also going to explore some common GI infections like gastroenteritis. We'll talk about acute pancreatitis, diverticulitis, and appendicitis. And then we'll talk about IBS and IBD. We'll wrap up today's lecture talking about hepatitis, including symptoms and treatment. Get ready to become a GI expert. All right. So before we tackle the GI exam, let's talk about abdominal anatomy. Remember, there are four quadrants in the abdomen: the right upper, the left lower, and the right lower. So in your right upper quadrant, you'll find the liver and the gallbladder processing toxins and fats, and the stomach nearby handling all the digestion. In the upper quadrants, we also have the pancreas and we have the spleen, which supports immunity and blood cell function. Going down into the left lower, we have the sigmoid colon, and then finally in the right lower, we have the appendix. All right, so let's talk about basics of the GI exam. So first things first, we're not actually going to do anything. We're just going to take a look. So we look at the abdomen. We'll note the shape and the movement, and we'll check for any masses or distension that we can see. Next up, auscultation. We're taking a listen. Listen for vowel sounds in each quadrant for 2 whole minutes. Yes, 2. I know that's a long time, but it's really important that we really listen for those vowel sounds. So normal vowel sounds are low-pitched and sound like they're a gurgling noise. We typically hear 2 to 5 sounds per minute, and that's considered normoactive vowel sounds. If we hear less than that, it would be considered hypoactive, and more than that is hyperactive. Now, if we hear no vowel sounds at all in those 2 to 5 minutes, well, that's a problem. Those are absent vowel sounds, and that could be a sign of a serious GI complication. So we'll need to investigate that further. So we've taken a look and we've listened, but now we need to percuss. So what you'll do is you'll place a finger on the abdominal wall and tap it twice with your other hand and listen for sounds. If you hear a hollow sound, this is called tympany and is over air-filled structures like intestines. If you hear dullness, this is over solid organs or masses like cancer. So for palpation, this is when we're feeling the abdomen. So we'll take a good look at the abdomen and we'll start by lightly feeling around in all four quadrants. Note the shape and the movement and check for any masses, distension, or skin changes. After you do a light palpation, go a little bit further in, and this is where you can really elicit pain or feel structures, and it's really helpful for diagnostics. Okay, so this is what we just talked about. First up, we're just looking at the abdomen for any irregularities or masses. We're taking a listen with our stethoscope to each quadrant. We're percussing to find all the organs and see if there's any abnormalities. And finally, we're feeling around for any masses or any abnormalities as well. Okay, so moving on to GERD. So what is GERD? Gastroesophageal reflux disease, or GERD, or acid reflux, is a common condition that many patients face. So what exactly is it? Well, it's when gastric contents reflux up into the esophagus due to relaxation of the lower esophageal sphincter. There's a lot of risk factors for GERD. One of the big ones is over 50 years of age. Obesity is another big one. We also see GERD more frequently in patients with hiatal hernias, those who smoke, and pregnant women, those who use NSAIDs frequently, consumption of spicy, fried, or acidic foods, and caffeine or alcohol consumption. So what do the symptoms look like? Well, heartburn and regurgitation are the big ones. You might also note that the patient has a cough or hoarseness. They might even have asthma symptoms, which is why it's really important to pay attention to the symptoms because sometimes they don't always present like we think they should. Sore throat is another big one, or even feeling that something is stuck in the throat. And finally, dental erosion. That acid is eating away the enamel of the teeth. So, with GERD, there might not be any physical findings. You'll have to rely heavily on the patient history. So, ask things like, are you having any burning in your chest? Are you belching frequently? Are you having any nausea or vomiting? How often are your symptoms occurring? Are they worse when you're lying down? And are you eating a lot of spicy, acidic, or fatty foods? Now, there's also some red flag symptoms we need to be sure to ask about. Any difficult or painful swallowing or early satiety, meaning you get full after just a couple bites, are red flags that we need to refer out for an EGD to make sure nothing serious is going on, like cancer. So let's talk about treatment for GERD. As with many conditions, first up, the one thing you're going to recommend is lifestyle modifications. So, weight loss, smoking cessation, avoiding trigger foods, eating at least 3 hours before laying down before bedtime. Next up, if that doesn't work, we do have medications that we can try. These are H2 blockers and PPIs. So, your H2 blockers are H2 receptor agonists. They end in dine, so famotidine, cimetidine, and they block histamine H2 receptors in the stomach and work to reduce acid. So the good news is that H2 blockers work very, very quickly within 15 to 30 minutes of taking them. The bad news is that they will have to be taken multiple times throughout the day. Now, another thing you need to know about H2 blockers is that they can really come with a lot of symptoms, especially in our older patients. They can cause multiple central nervous system side effects like delirium, forgetfulness, and confusion. Our proton pump inhibitors, PPIs, are the heavy hitters. They end in zol, lisoprazole, and omeprazole. They reduce gastric acid production and promote esophageal healing. They do take longer to work, though. 3 to 4 days is really when most patients start to see improvement. Now, there are some side effects to taking long-term PPIs, like vitamin B12 deficiency and osteoporosis. So keep that in mind when prescribing. So let's say we've tried the lifestyle changes, we've tried medications, and those just are not working for our patients. What are we going to do? We're going to actually refer them out to GI for possible interventions. So they might do an EGD to see what's really going on. Now, if the patient is obese and having GERD symptoms, bariatric surgery might be an option. Another procedure, Nissen duplication, is a surgery where they essentially reinforce the lower esophageal sphincter, and that stops the reflux for good. Okay, so taking what we just learned about GERD, let's practice. So the nurse practitioner is prescribing a medication for a 77-year-old patient with gastroesophageal reflux. Which of the following medications would be the best choice for first-line therapy? Is it A, bismuth subsalicate, C, calcium carbonate, C, famotidine, or D, Prevacid? I'll give you a second to take your guess. All right, so our correct answer is D, a proton pump inhibitor. So basically, we're doing this because it's the best choice of a short, aggressive treatment for geriatric patients who have a high risk of complications from GERD. We don't want to do high doses or long-term use of PPIs because this can increase the risk of fractures or malabsorption. So choice A is incorrect. We're not going to do salicylates in elderly patients because it can cause severe constipation. Choice B is also incorrect. Tums are great for breakthrough symptoms of GERD like heartburn, but really it doesn't treat the problem. It's more of just a band-aid. Choice C, an H2 receptor agonist, is an awesome alternative to treat GERD, but not with elderly patients. Remember, it can cause delirium, medication interactions, and even renal clearance can be compromised. So we want to be cautious of H2 receptors in our elderly patients. All right, let's move on to peptic ulcer disease. So peptic ulcer disease is often confused with GERD, but they do share one common factor, and that is gastric acid. So with peptic ulcer disease, that gastric acid known as pepsin erodes the protective mucosal lining and creates ulcers in the mucosa. We see gastric ulcers, ulcers of the stomach, duodenal ulcers, ulcers of the small intestine, and even esophageal ulcers. Our common culprits for peptic ulcer disease are the bacteria H. pylori, NSAID use, alcohol consumption, smoking, and family history. So, in order to identify the ulcer location, we have to pay attention to patient symptoms. For duodenal or small intestine ulcers, patients might complain of a burning or gnawing pain. The pain is usually located between the breastbone and the navel. Pain often occurs during sleep or nighttime, and here's the big one, it gets better with eating, after eating, or taking antacids. Gastric or stomach ulcers, on the other hand, eating actually makes the pain worse. The pain will intensify 2 to 3 hours after eating, and antacids really don't seem to help that much. We also want to ask about red flag symptoms like bloody vomit or stool and severe abdominal pain. These are possible symptoms of a GI bleed, and these patients should be referred to the emergency room immediately. So, unlike GERD, you might actually see some physical exam findings with peptic ulcer disease. Patients may have abdominal pain or epigastric tenderness. For diagnoses, our gold standard is an EGD, but for patients who can't tolerate that, a barium swallow study may work. As far as testing for H. pylori, we have a couple different options. We have the urea breath test, stool antigen testing, and urine ELISA testing. We'll also do lab work like CBC, a CT scan, and X-rays. So for red flag symptoms, we're going to take note of any intense epigastric tenderness, tachycardia, or abdominal rigidity. These are all signs of an acute abdomen and immediately need to be sent to the ED. So let's talk about treatment. The goal, of course, is to alleviate the symptoms, promote ulcer healing, and prevent complications. So one of the ways we can do this is identify the cause. Let's say it's medication like NSAIDs or long-term corticosteroid use. If possible, we'll just discontinue those medications. But let's say our patient tested positive for H. pylori. What would the treatment be then? So we have two different options. We have triple therapy and quad therapy. It's important to note that both of these are actually first-line treatment. There's no incorrect option. It's really just provider preference. Triple therapy is a PPI like pantoprazole, clarithromycin, and amoxicillin. Or if a patient's allergic to amoxicillin, they can use Flagyl. So remember, for triple therapy, pack that ulcer. P for PPI, A for amoxicillin, and C for clarithromycin. For quad therapy, we're still keeping that PPI, but we're adding Pepto-Bismol, tetracycline, and Flagyl. So for quad therapy, remember, treat my belly pain. T for tetracycline, M for metronidazole, B for bismuth salt, and P for your PPI. So how are we going to know that the treatment is effective? We're going to do that urea breath test again. If it's negative, great, we've treated the problem. If it's still positive after treatment, we want to refer these patients to GI. They may need surgery like a partial gastrectomy if therapy fails. Let's practice. So you have a 54-year-old male patient reports recently being hospitalized for a perforated peptic ulcer. In addition, he reports frequent use of over-the-counter pain medications for osteoarthritis in his right knee. What pain medication may cause gastrointestinal perforation? Is it A, ibuprofen, B, capsaicin, C, topical lidocaine, or D, acetaminophen? I'll give you a second to decide. All right, do you have your answer? Let's see what it is. All right, so if you guess A, ibuprofen, you'd be correct. So remember, NSAIDs may cause GI ulceration, bleeding, and even perforation, so make sure to educate your patients on these complications. Capsaicin and lidocaine are both topical pain relievers and do not increase the risk of gastric perforation. Acetaminophen, remember that's the pain reliever associated with liver dysfunction, is not associated with gastric perforation. All right, let's move on to some acute conditions. First up, we have gastroenteritis, or inflammation of the GI tract. You might have also heard it referred to as the stomach bug. So there are three different types. We have viral, bacterial, and protozoal. So viral is by far the most common type. It's caused by the norovirus in 90% of cases. This one's highly, highly, highly contagious. So if someone you know has it and you've been around them, chances are you're likely going to get it as well. Symptoms include stomach pain and vomiting, fever, and watery diarrhea. For bacterial gastroenteritis, this one is usually caused by food: Salmonella, E. coli, Campylobacter, and C. difficile. Symptoms include cramping stomach pain and B for bloody diarrhea. So think B for bacterial, B for bloody diarrhea. And finally, protozoal. This one is our least common. It's caused by Giardia and Cryptosporidium. Symptoms include cramping and vomiting, diarrhea, and another differentiator, general malaise. All right, diagnosing and treating gastroenteritis. So this is primarily a diagnosis that revolves on history and symptoms. So for history, you're going to ask about recent travel, their food history, any recent sick contacts that they've been around. Symptom-wise, we'll ask about onset of symptoms, duration, severity, frequency of symptoms, characteristics of stool, characteristics of vomiting, and then move on to our physical exam. Now, of course, we're looking for signs of dehydration, so be sure to look at mucous membranes, make sure they're not dry, check for skin turgor, and then, of course, with any GI complaint, we're going to do an abdominal exam. So treatment-wise, you might have heard of this referred to as a 24-hour bug, and that's true. Most cases are self-limiting, so we'll focus on supportive care. Think rehydration with oral electrolyte fluids like Pedialyte, a bland diet like the brat diet, so bananas, rice, applesauce toast, really any bland food the patient feels like they can keep down. And then for patients with severe diarrhea, maybe some anti-diarrheal medications. So for bacterial or protozoal cases, we'll treat with antibiotics. For C. diff, vancomycin. For Campylobacter, macrolide or fluoroquinolones. Shigella will be treated with ciprofloxacin. Traveler's diarrhea with fluoroquinolones. And protozoal infections with flagyl or tinidazole. All right, let's move on to a specialized abdominal exam. So the Carnet's test is a valuable tool for differentiating between abdominal wall pain and deep visceral pain. So what you'll do is you'll have the patient lie in a supine position and relax their abdominal muscles. While they're doing this, you'll have them point to the area of pain. Remember that area. Next, you'll have the patient lift their head and shoulders off the table, kind of like they're doing a sit-up. And when those abdominal muscles are flexed, we're gently going to press on the area of pain. If the pain is unchanged or increases when flexing, that suggests that the pain is related to deeper visceral structures. If the pain decreases or is alleviated with flexion, the pain is likely originating from the abdominal wall. All right. Next up, we have cholecystitis, and this is inflammation of the gallbladder, often caused by gallstones blocking the cystic duct. So, risk factors, females are a big one. Over the age of 40 is another big one, and we usually see this in Caucasian women. For smoking, pregnancy, and rapid weight loss, as with gastric bypass surgery, are other big risk factors. Symptom-wise, patients often complain of right upper quadrant pain, and it usually radiates to the back or the arm. It's not uncommon for these patients to come into the ED thinking they're having a heart attack. The pain gets worse with eating, they might have some nausea and bloating, and they might also have bilious vomiting. So for diagnosis, we'll start with a specialized exam technique, and the most common one is Murphy's sign. So what you'll do is have the patient lie on their back, and you'll palpate deeply that right upper quadrant while the patient is inhaling deeply. If there's any pain, this helps confirm the diagnosis. We'll also do tests like a CBC, CMP, LFTs, ultrasound, CT scan, and a HIDA scan as well. All right, let's practice. So we have a 35-year-old female patient present to the urgent care complaining of right upper quadrant abdominal pain for 3 days. The pain is intermittent and worsens after eating. She endorses 3 episodes of bilious vomit today. Her vital signs look okay, and her BMI is 28.6. So when you perform the abdominal exam, you ask her to inhale and hold her breath as you palpate her right subcostal area. As you do this, she grimaces. This is known as A, positive Homan sign, B, positive roasting sign, C, positive Murphy sign, or D, positive McMurray sign. I'll give you a second to take your guess. All right, does everyone have their guesses? So the answer is C. The Murphy's test is performed by applying pressure to the right subcostal area as the patient holds their breath. If the pain is elicited, this is suspicious for acute cholecystitis. Now let's walk through our wrong answers. So A, Holman's sign is a specialized technique we perform when we suspect a DVT. Choice B, a Rostig sign, is another sign you may very well do in the workup for this patient, but it's actually checking for acute appendicitis. So this is where it's important to pay attention to the patient history and presentation. Choice D, McMurray's test, is an orthopedics exam. We use this to check for meniscal tears. Moving on to pancreatitis, this is inflammation of the pancreas, and it can look like cholecystitis in a lot of ways. Risk factors include gallstones, excessive alcohol consumption, high triglycerides, abdominal trauma, and medications like corticosteroids, certain antibiotics, and even anti-diabetic drugs. Symptom-wise, these patients are feeling a sharp upper left or epigastric pain after eating or drinking. It might also be accompanied by nausea and vomiting. So diagnosis is based on symptoms and exam. So symptom-wise, we'll have all these symptoms I just listed, and exam-wise, you'll see very specific things. Two of those being the gray Turner sign, which is flank ecchymosis or bruising, and the colon sign, bruising or ecchymosis around the umbilicus. We'll also run some lab tests like BUN, hematocrit, lipase, amylase, and do a CT or MRI to confirm. Treatment-wise, this is an emergency. These patients go straight to the ER, and treatment is based on cause. So we'll always treat these patients with fluid resuscitation with lactated bringers and pain management because this is a very painful condition. If the patient has pancreatitis induced from gallstones, an ERCP or cholecystectomy will be performed. As far as infection, we'll treat the underlying cause. And if the pancreatitis is induced by high triglycerides, we'll actually put these patients on an insulin drip because that lowers triglyceride levels. All right, up next is diverticulitis. This is inflammation of the colon's tiny pouches. And we used to think this was caused by consumption of seeds, nuts, or popcorn, but that turns out that is not actually the case. Risk factors are actually increasing age, low fiber, high fat diet, obesity, smoking, and NSAID use. Symptoms include abdominal tenderness, a palpable mass, and that's actually probably an abscess that you're feeling, and hypoactive bowel sounds. So for red flags, we want to look for symptoms of shock, hypotension, tachycardia, abdominal tenderness with guarding and rigidity. These are signs that an acute abdomen may be indicating perforation. So these patients, again, should just go straight to the ER. As for workup, we're going to do a CBC that'll show elevated white blood cells, and we'll look for inflammatory markers like erythrocyte sedimentation rate and C-reactive protein. We'll also do a CT, and that will show thickened bowels. If these patients are stable, we can treat them outpatient with ciprofloxacin or Bactrim and Flagyl. If they're unstable, they need to go to the hospital for IV antibiotics. All right, so appendicitis is marked by inflammation of the appendix. So we'll see right lower and epigastric pain, nausea and vomiting, and fever and malaise. On exam, we may see bruising, rigidness, and tenderness. We'll auscultate the abdomen and likely hear hypoactive bowel sounds. Now, there are actually a ton of specialized exam techniques that you can do for appendicitis. So McBurney's point tenderness is where pressure is applied to a specific point and elicits pain, and that's one of the most common specialized exam techniques. We'll also assess for the presence of rebound tenderness with Rosberg's sign, where pressure is applied to the left side of the abdomen and causes pain on the right. The Merkel test or heel drop test is when the patient stands on their toes and then drops down to their heels. If pain is elicited in that right lower quadrant, that's highly indicative of appendicitis. There are also other signs like obturator and psoas sign, which are done by the provider manipulating the legs and eliciting pain in the right lower quadrant. In terms of treatment, for mild cases, we can do antibiotics and fluids. For moderate to severe cases, these patients will require surgery, an appendectomy to remove the appendix. So here's a picture of the multiple specialized exam techniques we can do for appendicitis. We have the Bloomberg sign, and we have the psoas sign where we're manipulating the leg and causing that left or right lower quadrant pain. The Rosevig sign, like I said, you're touching the left side of the lower quadrant, and then the patient will have referred pain in the right lower quadrant. The heel drop test, again, the patient stands on their toes and drops down to their heels, and pain is elicited in that right lower quadrant. And then with the obturator sign, we're manipulating the leg where the patient will feel, again, pain in the right lower quadrant. All right, another question. So let's say we have an 8-year-old boy present to the ER fast track with his mother. You diagnose him with an acute perforated appendicitis. He's hemodynamically unstable and febrile with a temperature of 101.4. Upon physical exam, you know that his abdomen has profound rebound and guarding. His mother is refusing to consent to medical treatment of the child and wishes to return home to monitor the child at home. Which of the following is most appropriate next step in the management of this patient? Do you respect the mother's request? Or B, respect the mother's request but provide her with a prescription for ciprofloxacin? C, do you refer the patient for emergency surgery without the mother's consent? Or D, discharge the patient but provide the mother with a referral to a pediatrician? I'll give you a second to decide. All right, does everyone have their answers? So this one's a tricky situation, but what you need to know here is that this is an emergency situation based on the child's presentation. Failure to act could actually result in the death of this child. Therefore, C is correct. There's no need to obtain consent from a guardian if the situation is life-threatening and requires immediate intervention. Choice A, respecting the mother's request, would be fine if the child were not in a life-threatening situation, but that's not the case with this patient. Choice B, respecting the mother's request but sending them home with an antibiotic does not address the urgent nature of this patient's condition. And finally, D, we wouldn't refer this patient to an outpatient setting with a life-threatening illness. It needs to be addressed right then and there. All right, let's move on to irritable bowel syndrome. So, irritable bowel syndrome is a common GI condition characterized by abdominal pain, discomfort, and bowel habit changes. There are two types, IBS-C, which is IBS constipation, or IBS-D, which is IBS diarrhea. So risk factors include female gender and stress. To diagnose, we have the Rome criteria to help us out. So one of the caveats is that there must be recurrent abdominal pain at least 1 day a week, accompanied by two of the following criteria: pain related to defecation, a change in frequency of stool, or a change in the appearance of stool. Treatment-wise, it depends on the type. So for those who have IBS-C, we'll try fiber supplements or laxatives. For IBS-D, we're doing antidiarrheal agents like loperamide or probiotics. Education is really important with IBS, and mainly it is focused on avoiding trigger foods. So for a lot of people, these are wheat, dairy, and even some vegetables and fruits. So IBS is irritable bowel syndrome, but we also have IBD, and that's inflammatory bowel disease. This involves inflammatory conditions of the GI tract that cause intestinal damage. There are two types. We have Crohn's disease and ulcerative colitis, or UC. So for Crohn's disease, Crohn's causes strictures, inflammation, skip lesions, and they're present anywhere in the GI tract. Symptom-wise, these patients will have right lower quadrant pain, nausea or vomiting, weight loss, and non-bloody diarrhea. For ulcerative colitis, they'll have ulcers in their mucosal lining, and they start at the rectum and work their way up the GI tract. Symptoms include bloody diarrhea with mucus, left lower abdominal pain, and tenesmus, or pain with defecation. Another thing we'll want to watch out for with ulcerative colitis is toxic megacolon. This is essentially where the colon widens and can actually perforate. So any signs of abdominal distension, fever, and severe pain, we want these patients to go to the ED right away. As far as diagnosing and treating IBD, there's a lot of work that goes into it. So first up, we'll start with history. We'll ask about bowel habits and onset of symptoms. Next up is lab work. We'll order CBC, take a look for anemia, elevated white blood cell count, and thrombocytosis. We'll do an X-ray to check for bowel obstruction. We'll do a CT or MRI, which is not only helpful for diagnosis, but help to track the progression of the disease as well. And finally, our gold standard is endoscopy with biopsy to determine the type. Treatment-wise, the goal, of course, is resolution of symptoms. We have medications like mesalazine, corticosteroids, and biologics like Humira. And last but not least, we have hepatitis. So remember, there are a lot of different types of hepatitis, which is just inflammation of the liver. So hepatitis A is spread through a fecal-oral route. Hepatitis B, bodily fluids like blood, semen, and needle sticks, and same for hepatitis C. Now, hepatitis D and E are less common, but just know that hepatitis D is a complication of hepatitis B, which is easy to remember because they rhyme, and hepatitis E is really rare in the United States. So let's talk about symptoms. So remember, we're thinking liver dysfunction here. So of course, we'll see some jaundice of the skin or sclera and maybe dark urine, but other symptoms include fever, malaise, myalgias, and then those dark or clay-colored stools and nausea and vomiting. So how do we diagnose and treat? Well, we're going to ask the patient, tell me about your recent travel. Do you have any new tattoos or piercings? Any drug use? Occupational hazards? And then we'll do an abdominal exam and check for hepatomegaly. Lab testing will include a CBC, liver function testing like AST and ALT, coagulation factors like PT and INR, and hepatitis titers. So treatment-wise, hepatitis A is usually self-limiting. It resolves on its own. So we're just doing symptomatic care, rest, hydration, and very close monitoring. For hepatitis B, we're vaccinating them. And also we might use antivirals like lamivudine. For hepatitis C, we're using pegylated interferon alpha and ribavirin. So one more question to practice. The hepatitis B vaccine is indicated for newborns in the first 24 hours of life in which scenario? A, it's anticipated that the infant will be exposed to infected blood or bodily fluids. B, the mother is hepatitis B surface antigen negative. C, the infant is going to be formula fed. Or D, the mother is hepatitis B surface antigen positive. Go ahead and take your guess. All right, do you have your guess? So the answer is actually B, if the mother is hepatitis B surface antigen negative. So a mother's hepatitis B profile is taken into account as well as infant weight when determining the hepatitis B vaccine series should be started with a newborn. If a mother is hepatitis B surface antigen negative and the infant weighs over 2 kilograms, the vaccine series should be started in the first 24 hours. Choice A is incorrect. The World Health Organization recommends hepatitis B vaccination for all infants, regardless of exposure risk. C is also incorrect. Breastfeeding or formula has no bearing on deciding when and timing of hepatitis B vaccination. And finally, choice D is also incorrect. If a mother has a positive hepatitis B surface antigen test, this indicates active hepatitis B. The infant must start on the hepatitis B vaccine series and hepatitis immune globulin within 12 hours of birth to ensure proper immunophylaxis. All right, guys, that wraps up our GI review. Does anyone have any questions? Awesome. Well, I want to thank you. Where can I do practice questions? That's a great question. So what you can do is go onto our website. It's right there on the screen, and you can look for question bank and on-demand videos and a 3-day live review. Those are all great resources to help you practice for your boards. Also, if you want to go ahead and scan that code in the bottom right corner, that is going to register you for every single webinar that we do. We're doing them on a weekly basis. Finally, another great resource is social media. We post practice questions all the time, and they're great to just do very quickly while you're scrolling through social media. So that is all of the cool stuff we have going on at Archer Review and great resources for you to utilize for your boards. Thank you again, and we'll see you next time.